Okay, we're now live, and it's always a challenge jumping across. This is Elliot Fishman, and hello, how are you? Welcome to our monthly quiz. I got a dozen cases. Let's get started. Patient has back pain, rule out this section. You notice soft tissue infiltration. Those are the iliac vessels. You could say maybe the patient has lymphoma, maybe there's retroperitoneal fibrosis, but it's almost too bulky. It's infiltrating downward, right, along the common iliac on the right and to a lesser degree on the left. So I have to admit I'd be thinking of lymphoma, some other infiltrating process. If the patient was a male, testicular cancer perhaps. What else could it be? What else gives you masses in the retroperitoneum, some sort of sarcoma? Those sarcomas usually don't surround vessels like that. They more displace things. And so you can think about that. Lymphoma is still a good bet. Doesn't look like a carcinoid. And things in the posterior portion of the abdomen, neurogenic tumors, nodes, things like that are considered. And this was a ganglioneuroma, an unusual tumor. Usually you see them arising by the foramen. Usually they're low density, like classic neurogenic tumors, but it is kind of surprising to be so infiltrative. So a very interesting case. Sticking with the back pain, rule out aneurysm or stone. I'm looking at these images. Do you see anything? Looking at the pancreas, is that a bit full? Is there a little node over here in the left parietic region? Anything going on that bothers you? Well, maybe it's a node, but now we're coming down into the pelvis. Kind of a little bit like the last case, this infiltrating process. But in this case, you see infiltration of the sacrum, including the sacral foramen, which are infiltrated. You could say myeloma, you could say plasmacytoma, you could say chordoma is low-lying. Now, chordoma is more destructive than infiltrating large soft tissue mass. It's not going to be extramedullary hematopoiesis. It's just way too bulky. This has to be malignancy. And we go through things that relate to bone and soft tissue. We said myeloma, a chondrosarcoma, osteosarcoma, something like that. But another thing you need to think about with infiltration and extension, and we tend to forget about, would be lymphoma. And this was B-cell lymphoma involving the spine and the presacral space tracking down by the piriformis muscles. Very, very nice example. Right upper quadrant pain, you see a large mass, non-contrast scan. From this scan, it could be kidney, it could be adrenal. From this scan, it's adrenal. And with contrast, it's vascular, central necrosis. Neovascularity is present. It's a large adrenal mass. When a mass gets this large and has this central necrosis, mottled enhancement, neovascularity, it has to be a primary adrenal cortical carcinoma. Yes, it could be a met occasionally, like melanoma or hepatoma. Doesn't have the look of a pheochromocytoma. It's not anything benign. We've had some strange ganglioneuromas perhaps, but I'm giving 95% primary adrenal cortical carcinoma, which this indeed was. Very nice case. Another patient, same thing, mass, which is also adrenal, but you can see here the lesion is mainly fat density, -60 to -140 Hounsfield units, but there's high density within it, and it's just compressing a bit the IVC. Well, when you have an angiomyolipoma, high density usually means the lesion has bled. Most angiomyolipomas above 5 centimeters are going to be resected, and this indeed was a large angiomyolipoma of the right adrenal gland that previously bled. Very nice example. Contrast the myelolipoma with that primary adrenal cortical carcinoma. Okay, sticking with back pain, now we have a mass in the right and left adrenal. In addition to the fact the mass is oval, there's also stranding around it, which means it bled. Bilateral adrenal bleeds. You can have trauma, but that's usually right adrenal, and typically you'll see some liver injury or kidney injury. Patients on anticoagulant therapy are the things I think about for bilateral bleeds. The problem with bilateral bleeds, the patient can go into Addisonian crisis, so it's a very, very important diagnosis to make. Here it is again on the coronal views with the stranding, and this was Coumadin-related bilateral adrenal hemorrhage, and yes, till we told them they didn't know it, but they figured it out after. The patient was Addisonian, which is why the patient had a lot of very strange symptoms. An adrenal hemorrhage, here's some of the causes. Yes, it can be tumor, but tumors aren't going to be bilateral bleeds spontaneously. Anticoagulant therapy or stress are the ones I think of most, but especially anticoagulant therapy. Patient with suspected pancreatic mass. You look, there's no dilated intrahepatic ducts or a pancreatic duct, and the vessels look really good. There's the patient's hepatic artery, GDA. Everything looks good, but there's a large mass there. It has some vascularity. It's very smooth. Now, our rule is if you see a mass near the pancreas, which simulates a pancreatic mass, but there's no duct dilatation, you got to be thinking that it's not the pancreas and it's coming from duodenum. Tumors in the duodenum that are large, commonly are more vascular, but they don't need to be, would be something like a GIST tumor. Carcinoids occur in this location as well. Metastatic disease occurs here as well. But when you think about it like this, you're going to be talking about a GIST tumor. Just a really nice example. Another patient, GI bleed, large mass right lower quadrant. The mass is ulcerated. It's not from the bladder. There it is, large mass. Interestingly, it's not obstructing bowel. You give me a large small bowel tumor that's not obstructing bowel, you could think of lymphoma, but lymphoma is usually infiltrating. The other thing I think of is a tumor that's exophytic. So potentially metastasis or a GIST tumor. Patient has no site of primary tumor here, and I didn't tell you the patient did have a primary tumor. So this would be the main finding. Adenocarcinoma, no. Lymphoma, unlikely. The one that you got to be thinking about, pushing the vessels but not obstructing bowel, is a GIST tumor with ulceration. Remember, GIST tumors with ulceration will commonly bleed. Okay, another case, multiple lesions, liver and spleen. I got to be thinking about lymphoma. I got to be thinking about metastasis like melanoma. You want to make sure you're not dealing with something like sarcoidosis. But then where does the bleed come in? Multiple liver and splenic lesions. You're looking down at the bowel. The bowel is somewhat thickened. Look at the lesions on the cinematic, both in the spleen and liver. I got to be thinking malignancy. If the patient was febrile, you could think of abscesses, but they're usually small and not so large. And this was metastatic melanoma. So the patient also had a bowel lesion, which we didn't see, which likely explained the patient's GI bleeding. Just a very, very nice example. Abdominal distension. I see ascites, I see cirrhosis. Kidneys are okay. Look at the gastric fundus. You see how the stomach is thickened at the GE junction? And this thickening of the body of the stomach, more impressive on the coronal views. Look at this infiltration. So one thing I could say is maybe this is carcinoma, adenocarcinoma of the stomach. But when I start seeing things that infiltrate like that for long lengths, I also need to think about linitis plastica, which typically occurs from things like breast cancer. Linitis plastica is an infiltrating process, so even an adenocarcinoma can have that appearance. But here what you're showing is the importance of good gastric distension. We see the thickening, we see the infiltration in this patient with breast cancer and involvement of the patient's stomach. Fever, shortness of breath, septic emboli. You're thinking of something infectious. But you also need to know is with the haziness around the masses, you could be thinking about hemorrhagic metastasis to the lung. Could this patient have a thing like a choriocarcinoma or other tumors that give you very, very vascular lesions? Look how many lesions there are, but look at the halos around them. Yes, you can see that with embolic phenomena, IV drug abuse, things like that, but also tumor related. Here it is on the MIP imaging. And this was lymphoma. Wow. HIV patient. I would think of infection, I'd think of metastasis, but lymphoma, we always miss lymphoma. Wherever it occurs, we don't think about it. It's a chameleon. It has so many appearances. And in the lung, this appearance is a very nice one, particularly in an HIV patient. HIV patients, lymphoma always moves up very high on your list. And you also probably would have thrown in Kaposi sarcoma as a vascular lesion. Left upper quadrant pain, cystic lesion, pushing on the stomach. What is it? Is it from the, it's not the adrenal. I can see the adrenal Is it off the pancreas? Is it coming off the stomach? What is going on? Well, I think when you look at all the images, it's probably coming off the tail of the pancreas. You're thinking about a serous cystadenoma, oligocystic. You would consider a pseudocyst. You would consider an MCN. But it's very well defined, and this was a serous cystadenoma. Remember, serous cystadenomas, patients are in their 60s. MCN patients are in their 40s. And with MCNs, you often will see calcification around the edge. Serous, you may see calcification centrally. Serous, we typically talk about septations and honeycombing, but you can get an oligocystic, which is a great mimicker of other things. Another mass, tail of pancreas. This one has a central calcification, more septations on the coronal view and with MIP. You really can see the septations nicely. It looks cystic, tail of pancreas. This is more classic than the prior case. You can think about a big differential, but at the end of the day, till proven otherwise, this is a serous cystadenoma. Central calcification, cystic, large, well-defined serous cystadenoma. These are benign lesions. They're often resected because the patients have symptoms, but there is no malignant potential possible. And that's, thank you. That's a dozen cases, and I can't see everybody so I don't know who's on, but I hope everyone's doing well. And when I stop sharing, which I'm going to do in a moment, this lecture will be over. So a dozen cases. I hope you like them. See you, I think it's always that third Thursday of the month. Have a great day, people.